Good afternoon, everyone. My name is Rebecca Schaffer. I'm a dentist, but I am a specialist in orofacial pain, and I subspecialize in taking care of folks with EDS. I'm really happy to be here. It's an honor. And let me start by saying everything that you've heard before my talk is relevant to everything I'm going to say and probably everything that everybody will be saying afterwards. So this really is a global conference. I have no disclosures except for one. I do not have EDS, but I am a left-handed female, which puts me in one of the smallest minorities on the face of the earth. And I just Googled it. I'm officially neurodivergent because I'm left-handed. So there you go. Very proud of it. So what I hope to do is give you a very short but thorough overview. And I'm sorry, the notes are not up there. Anyway, of dental periodontal and orofacial pain-related issues that people with EDS face. So, oh, there we go. Thank you. So first, the tooth and its supporting tissues. Collagen of all types is present in every single dental tissue, in enamel, dentin, gingiva, attached gingiva, pulp, cementum, and most importantly, the periodontal ligament. So it's easy to see how a lot can go wrong when you have a bodily structure that's mostly collagen. And again, just like everything with EDS, it's highly individual. So some people are going to have a lot of problems with their teeth no matter how diligent they are about caring for them. And some people will sail through without any problems. There's no good data on the exact dental anomalies that we see in EDS. We know that the mucosal tissue is thin and bleeds easily. There are some studies that show calcification of the pulp, commonly known as pulp stones, dysplasia of the enamel and the dentin. We see these changes in people without EDS as well. And just like you've heard a lot of times today, and we'll hear again, there are very few studies. There really haven't been any studies to quantify or qualify the changes that we see. And so I don't have a lot of time, but I want to spend a minute here. We know that there's a very poor response to local anesthesia. We all know that. Everyone in this room knows it, and I'll talk more about that in a minute. Orthodontics can be very challenging because the relapse rate is very high. The last bullet point is especially important. Obstructive sleep apnea is very common in people with EDS, and it doesn't fit the usual phenotype of an overweight man with a thick neck. I see it in a lot of very skinny women with tiny little necks. And my ENT colleagues will agree with me that sometimes the best treatment for obstructive sleep apnea is something a dentist makes, is an oral device. They don't always work because the pharyngeal collapse and insufficiency that's common with EDS isn't fixed by pulling the mandible forward. So those of you who've been diagnosed with obstructive sleep apnea and are thinking about an oral device, it's a good idea to find an ENT. We just met one, but there may be a few others out there who actually understand EDS and can analyze the tissues in your throat, because an oral appliance might not work for you. So I just wanted to throw that out there. So local anesthesia and why, thank you. The people in the back are doing a great job. Why doesn't it work? The short answer is we don't know. We think it has something to do with the molecular weight of the compound. But 88% of people with Ehlers-Danlos experience inadequate pain prevention, which can make going to the dentist even more awful than it is for everybody else. I get that. Whereas only 33% of people without EDS have inadequate pain prevention. There is a local anesthetic out there. It's called Articaine. The brand name is Septicaine, which is 4% with 1 to 100,000 epinephrine. That is the only thing that works for people with EDS, and even that doesn't work as well or as long. So my last slide is gonna show you ways that you can talk to your dentist. I hear it every day, the frustration that people have in going to the dentist and telling the dentist it's not working, and the dentist is just shaking their head and assuming that you're crazy. It's just not true. It really doesn't work. It is easier to get numb on the top, the maxilla, because the bone is a little bit thinner. And again, like I said, most dentists are unaware of the problem in EDS, and it can lead to a whole lot of frustration. So what I'm trying to show you here is that your mouth is not Las Vegas. What goes on in your mouth does not stay there, okay? Your mouth is the gateway to your body. Sometimes I tell patients that I'm a fortune teller, but I don't look at your palm, I look in your mouth. So, periodontal disease and systemic illness. Unmanaged periodontal disease causes inflammation. One of the markers of inflammation is C-reactive protein, and people with periodontal disease have been shown in various studies to have 9 times the amount of C-reactive protein in their blood than people without periodontal disease. Inflammation isn't good for anybody, but it's a huge risk factor for people with EDS. There's a relationship between periodontal disease and MCAS. Again, nobody's really quite sure what it is, and we need to do a lot more research on it. The rarest form of EDS is, in fact, periodontal EDS. I've only seen one person with it, but any type of EDS will affect the periodontal tissues because, again, they're just the periodontal ligament. Ligament is the operative word here, is what holds your teeth to the rest of your body. So, the mouth being the gateway to the body, I always tell people, treat it well. Treat it like it belongs to someone you love. Try to brush twice a day, mindfully. You've heard that word a lot, and we're going to hear it again. When you're brushing your teeth, don't think about your horrible boss or, your annoying teenager or anything else. Ask yourself, am I covering every surface of every tooth? We say to brush for 2 minutes. There's no science behind that, but 2 minutes is better than 10 seconds, so that's what we tell people. You can play a song. I tell my teenagers to put together a playlist of their 14 favorite songs and use that as their toothbrushing playlist. An electric toothbrush has been shown to work better. A good electric toothbrush, I don't want to say brand names, but there are a couple out there that the studies have shown do work better than manual toothbrushing. If you have mobility issues, and I know that there are a lot of you in the audience who have mobility issues and toothbrushing is difficult, flossing is difficult, get in touch with me after the meeting or find me in the hall because there really are devices out there for people with mobility issues that can make it easier for you. Flossing once a day is fine because those bugs that take up residence between your teeth and your gums, they take about 24 hours to reproduce. But they're the bugs that get into the rest of your body and cause a whole lot of problems. Obviously, we should all be avoiding sticky sweets and junk food and ultra-processed foods. We all know that. And the hard part is finding a dentist willing to understand your medical issues. I'm single-handedly trying to change that. So this is just an example of everything that can go wrong. When you have untreated periodontal disease, it basically affects every major organ system. The take-home being inflammation is not a good thing. And I understand there are people in the audience who can't take their nutrition by mouth and who use other means. But try to think about whatever diet works for you, whatever your gastric issues are. Try and make it a diet that's meaningful and helpful and avoid the empty calories, whatever that means to you. So I want to switch gears now and talk about orofacial pain, TMJ issues. Obviously very common in this group of people. The TMJ is a joint. TMDs are an umbrella term for temporomandibular joint dysfunction. Under that umbrella are a whole lot of different diagnoses with different codes, which can drive you crazy when you're trying to get insurance reimbursement, but that's another story. But what I've listed here are the most common diagnoses that I see in my EDS patients. Capsulitis is just inflammation and pain of the joint. The clicking and the popping is an articular disc disorder, and I'll show you a cartoon of that. And it can either pop back in place or it can get stuck. Obviously, painful muscles with referral, cervical instability, headache attributed to TMD, joint pain, and degenerative disease. So this is just another slide that shows you that studies between 40 and 100% of people with EDS have TMJ-related issues and pain. So the chewing muscles, the muscles of mastication. The four main chewing muscles, the temporalis, and I'll show you a picture, the masseter and the medial pterygoid all elevate or raise the mandible up. The lateral pterygoid is a funky little muscle that protrudes and depresses the mandible. The accessory muscles, if you look at, are neck muscles and muscles, throat muscles. The sternocleidomastoid, the trapezius, the posterior neck muscles. We palpate these muscles to see where the pain is and where it's referring to. The take-home message here is that there's really no point at which the chewing muscles, the neck muscles, and the trigeminal nerve and the cervical nerves begin and end. They all work together. So this is just a picture of the main chewing muscles. And this is important. People way smarter than me figured this out a few decades ago. So if you look, the X's are trigger points. That's areas of muscle that are not functioning properly anymore due to overuse or contraction. Muscles work by sheets sliding over each other, but these little knots or trigger points don't use oxygen properly and they've walled themselves off. And they can be very painful. The red is where the pain refers to. So this is the major muscle that holds your head to the rest of your body. And these are the areas that can be affected. So you can see that many headaches start with the sternocleidomastoid. Same is true for the masseter. So a lot of unnecessary root canals and dental procedures have been done by dentists and people who don't understand this. But the masseter, especially if you're a clencher or a bruxer, or if you live with chronic stress, has trigger points that will refer to the teeth, to the sinus, to the ear, which can cause ear pain, not real hearing loss, but perceived hearing loss, and certainly ringing in the ears. The temporalis This big fan-shaped muscle up here can cause pain in all your top teeth. The trapezius, neck pain, headache, upper cervical pain. So let's talk a little bit about the anatomy. The trigeminal nucleus caudalis, it's a longitudinally shaped nucleus, sits at the back of your head, and it's a switching station. The trigeminal nerve is one of your 12 cranial nerves, and it's responsible for everything that you feel in your head and your face. It's a sensory nerve with a very small motor component. It innervates everything, your teeth, your gums, your sinuses, your eyes, and a trigeminal, migraine is a trigeminal nerve disorder. So when you feel something on your face, your nervous system is sending that signal back to the trigeminal nucleus caudalis. But that nucleus also gets information from your cervical nerves, especially C2. And there's a lot of crosstalk. It's a switching station, and sometimes the signals get a little bit messed up as it sends the sensation, the message to higher areas in your brain. And this is important because it's been shown that cervical spine instability, even though that's a function of one of your cervical nerves, can cause a migraine, which is a trigeminal nerve disorder. So any one of the cervical nerves can cause a headache because of this crosstalk in this nucleus. And so the anatomy really demands that dentists, orofacial pain specialists, neurologists, orthopedists, physical therapists, the whole team, we really need to work together and step out of our silos. Again, this isn't Las Vegas. And by the way, everybody this morning is telling you that when people tell you that your symptoms are all in your head, for this particular session, they really are all in your head and your neck. So this is a template that all our students use at the dental school where I teach for every new patient exam. And I'd love to share it with all the other professionals in the office. It can be easily used as a screening device in any medical setting with simple online training and palpation technique, or you can call me aside and I can show you how to do it. If you answer yes to any of these questions, it's important that you refer yourself or your patients to an orofacial pain specialist. Now, there's a problem. Orofacial pain is a newly recognized specialty by the American Dental Association. It just got recognized as a specialty in 2020. It's billed under medical codes, which really makes it fill the gap between medicine and dentistry. And there's only about 400 of us in the whole country. Unfortunately, there are a lot of people who call themselves TMJ specialists. There's a lot of snake oil out there, and I don't want to denigrate anybody. If you need an orofacial pain specialist, I know, 2 minutes. Go to the American Academy of Orofacial Pain website and find a provider in your area. Prevention is the important thing. We are going to assume that everybody with EDS at one point is going to have a TMJ problem. So don't take big bites into those whoppers. Maybe slice your apples. Do some preventative stuff. And that involves postural alignment. And so I hope that all the physical therapists in the audience are aware of this and help patients avoid this. The important thing, again, and my colleague who spoke before me, surgery should be your very last option. I've heard so many horror stories of people who've had their joints replaced with EDS and it hasn't worked out. In the orofacial pain world, the evidence shows that we can manage your symptoms with reversible, non-invasive treatments. Now, that's going to be tailored to every single person. If you have MCAS, I might do things a little bit differently than if you don't. But surgery should never be an option, and it's really important that you consult someone who really knows about orofacial pain. I'm sorry to have to say it, but there's a lot of snake oil out there. whatever. Splints are used just like splints for any other joint. We can't directly splint your TMJ because we'd have to cut your face open, but luckily we can use your teeth. And again, they have to be designed by someone who knows what they're doing. The purpose of a splint is to unload the joint. The joint is a load-bearing joint, the most load-bearing joint in the body. There's not a lot of space in there, so when it gets inflamed, it's very painful. By placing a splint on your teeth, we can create some space in the joint and unload it, give it a chance to heal. This is a normal joint, and I know I'm running very short on time, and that's the little disc that's supposed to move with your joint. When you have clicking and popping, it's because that disc is out of place. That disc is held in together by ligaments, so people with EDS are extremely prone to clicking and popping, and again, this can be resolved with reversible, non-invasive procedures. Running very short on time, so this is probably the most important slide that I have for you. It'll be on the PDFs that you all get, or you can talk to me. This is a checklist for dental visits. So if you're intimidated by the dentist, which you should not be, use this, take it with you, check off everything that applies to you. If you hand it to the dentist and the dentist throws it aside without looking at it, get up and leave. I mean it, really, just get up and leave. I want to make this available to everybody. You have the right to be treated with respect. You have the right to good health. You have the right to be listened to. And since everybody hates the dentist, I get that. I get that you folks hate it even more because it's so frustrating, and I wish I could fix that. So we need a lot more research. We need a lot more awareness. There is no such thing as good health without oral health. And that is my email address. I know you're not supposed to take pictures, but if it's okay with the people in charge here, if anybody wants to take a picture of my email address, please feel free. I'm available whenever you need me. Thank you so much.